I think it just all comes down to we all want to do what's best for the patient. So just get engaged and get involved and get the support you need.
That's Dana McDaniel from Mosaic Life Care. You'll hear more from her later in our discussion on screening for social drivers of health. Welcome back to Cancer Buzz. I'm your host, Summer Johnson. Providers can screen for social drivers of health to understand and address the barriers that patients face in accessing treatment. But many cancer centers don't routinely collect this information. That's why ACCC developed a new tool to help cancer care teams screen for SDOH-related needs. We have a robust discussion today with two leaders of two oncology teams that tested the tool, both from different parts of the country. Our guests today are Dr. Richard Martin from Tennessee Oncology and Dana McDaniel from Mosaic Life Care. Thank you both for joining. Dr. Martin, tell us about Tennessee Oncology and the patients you serve.
Yeah, thanks for having me on this podcast. I'm a physician at Tennessee Oncology, which is a large community oncology program located in Middle Tennessee with 38 clinics and growing within that territory and part of the One Oncology Network, who are also aligned with operationalizing even larger social determinants of health screening goals. But within Middle Tennessee and Tennessee Oncology, we service a quite diverse community. Across that landscape, we have both urban and rural-based clinics. We have the largest Kurdish population in the United States in that immigrant community. We serve Latino communities, Black communities, rural white communities, all types of individuals. And we really pride ourselves in being a company that does truly treat all people, regardless of their ability to pay, their race, their belief systems, or their location. We've never turned down a patient for cancer treatment. We've given over $100 million a year in free drug. And we're just a group that, honestly, most of the safety net hospitals and other places in town, if patients don't qualify for their programs, send them our way. So working on issues of social determinants of health and cancer equity is really near and dear to what we do as a company.
Dana, talk to us about your cancer center.
So Mosaic Life Care is located in St. Joseph, Missouri. We take care of patients in a large portion of Northwest Missouri. We are a Mayo Clinic Care Network member, and we serve a rural and suburban community. At Cancer Care, we really strive to put all of the patient's needs at the forefront. So we definitely provide excellent medical care to these patients, but we also know that the ancillary services and assessing and addressing their social drivers of health is essential to improve their outcomes.
This is a question for both of you. Why is screening for social determinants of health important here?
Well, screening for social determinants of health is critically important. And I'm glad that the United States, our healthcare system, and really globally, we're appreciating that, which is that anytime you're trying to do something for somebody, all the other features that can create barriers or inform patient preferences, understanding their goals of care, are essential to achieving the best outcome and highest quality outcome possible. We have very easily learned how to apply this to understanding the facts about cancers at the molecular level, at the staging level, in order to inform right drug, right patient, right time. But executing that plan, getting the drug into the patient in a longitudinal fashion, executing their goals, does take incorporating those patient pieces into account. And those historically have been wildly overlooked, not only for people with, low means and low resources, but even people with higher means and resources. And capturing that data, being able to execute on it, help it inform your treatment plan is really essential. And it does help you identify individuals who might have greater needs or barriers. And then you connect that with programming or new tools, new strategies to help fulfill those needs. So that, again, ultimately, this is about achieving the highest quality of care for the people that we serve.
So it's essential to screen for the patients and their SDOH, because if we don't ask the questions or even the right questions, then we're not extracting that information from the patients and able to address those needs that they have. It's important for us as healthcare workers, and especially the people that are in the front line, to really understand those needs of the patients, because ultimately it affects the patient's health and well-being and ultimately their outcomes. And just understanding the SDOH provides more of a holistic care, and it really addresses the root causes of health inequities. And since SDOH factors such as the patient's education, employment, the communities, all of those components, since those factor into the patient's ultimate outcomes and how they're going to respond to certain things, it's just essential that we are asking those questions and asking the right ones.
How does screening translate to being able to better respond to patients' needs?
So the screening helps because, again, if we're not asking those questions, then we aren't able to really fully address those. We have a huge amount of resources that we can provide to patients, but we just need to know which ones are essential for them. So if we don't ask those questions, then we're not able to really help the patients as much as we possibly can. So, training the caregivers in the questions to ask and getting them to feel comfortable on how to ask the questions and how it really does impact the patient is something that we've really worked on doing here at Mosaic.
This is also a question for both of you. What prompted your program to participate in the ACCC pilot program?
So we were interested in this program because we know that SDOH is critical, and we know that a lot of our patients have SDOH needs. So what we wanted to do is be able to really initiate the screening and to be able to provide some education to our caregivers on what that means and how to address the needs of the patients. We knew that this QI project would really force us to do better, essentially. I mean, that's what a QI project is it makes you look through what you're doing now, what gaps that you have, and how you can fill in those gaps to better care for the patient. So that's why we wanted to be part of this. And we have a great team that was involved in being able to accomplish this QI project and make it successful.
Well, Tennessee Oncology, coming into this project, already had a fairly robust social determinants of health screening apparatus. We had participated in the OCM model, which is an alternative value-based care model with Medicare, with CMMI, which incorporated a lot of requirements and also just some incentives to start building out capacity for SDOH screening. And so we already came in with that as our landscape, but we want to continue to be pioneers in this space. And as a space that is continuously advancing with higher accountability and requirements from payers, and also, as I think Dana would agree, that the intentionality here is to provide better patient outcomes, that continuing to explore whether our model is the best or whether there are lessons that we can learn from other tools, other screening workflows to improve and have an iterative approach to innovation and improvement was really why we jumped in. And there were a number of questions on this particular form we identified that we don't currently ask. And so just keeping a very open mind, letting the frontline workers who administer this tool and really letting our patients give us their feedback and how this is perceived. We find that as extremely valuable information to help our company do a better job in addressing SDOH and health-related social needs for our patients.
Dana, how is this tool administered in your program?
Yes. So when our team was first formed, that was probably the biggest question, is who was going to administer the tool and at what interval and frequency would it be administered. So we did a lot of discussion and came up with, we wanted the patient to be screened as soon as possible so that we could address those barriers. So we decided to assess the patient at our chemotherapy education. And that was the initial screening that we completed. And prior to doing that, we wanted to ensure that the two nurses that would be administering this screening tool knew what SDOH was, knew what the tool was, and how it had implications on the patient. So we provided them some education up front, and then they administered the tool to the patients at the chemotherapy education. And then whenever they administered the tool, they would bring it back to our team, and then we would do any referrals that were needed based off of that assessment. And then the next time we administered the tool, we elected to do a 30-day reassessment just because of the timing of the assessment. When the patient was coming in up front, their needs may look different than 30 days later. So we wanted to keep that in mind and be able to address it up front. Then if there was anything that arose between those 30 days, then we would also be able to provide then. And then we had just kind of an as needed or, at the discretion of our social worker. And that's how we did any further reassessments. But that really helped us identify the patient up front. And then after that, we decided that even further, actually sooner, is when we would do the assessment with our nurse navigation team. And once they establish a connection with the patient, they would start doing the screening even before the patient gets in our door.
Dr. Martin, how did your team decide where to implement this program into your cancer network?
Yeah, from our standpoint, piloting anything well requires buy-in and not compromising your pre-existing workflows. So a lot of time and effort on the front end was spent identifying where this pilot would be best located in terms of clinics, in terms of roles, and in terms of implementation to add value while not minimizing from our already existing workflows. And for example, a lot of our SDOH screening is embedded within EMR steps and done through medical assistants, which trigger then for overview by our financial counselors. But training our MAs across clinics with so many other workflows that they're already doing for a temporary pilot that we could learn to expand or build off of was seen as probably not the right step. Ultimately, if the person who gets a positive screening result is our financial counselor. So then we looked at, within our collection of financial counselors who do a lot of our financial counseling as well as social work and nurse case management for the company, we looked at how many would we need to train to capture 30 patients, 60 patients, really get that nice deep dive qualitative assessment on how the tool is working. And we realized that across our clinics in our Chattanooga area, that's really covered by, his name is Brandon Gutteridge, and he does an amazing job and really had amazing buy-in from him to champion this project. So we only really had to train one person, and he could independently give us feedback on how he was delivering this in person, via telephone, via appointment, and give us kind of feedback from his standpoint on how the workflow is operating.
Dana, what was the impact on your existing workflows?
I think the first piece is the education. I know that our caregivers and providers know what SDOH is, but they didn't know the very significant details to it. So one of the things that changed our workflow is, first of all, educating our caregivers and providers. So we've actually worked as our team, the SDOH team that was developed because of this QI project, to create a simulation and then an education session to all pertinent front-facing caregivers. So that was something that was essential. And then with the workflow of administering the tool, we didn't really have a great workflow on how to administer the tool or who would administer the tool. So that was a change in workflow, was just administering it all together and then designating who would be the person to or the people to administer the tool. One thing I would like to point out is that everybody's role with SDOH is different, but really everyone has a role with SDOH assessment. So letting us be able to identify those patients at risk, really just taking that time to sit down with the patient and ask the questions, listen to them, and then connect them to the appropriate services so that we can tailor their care and ultimately improve their quality, and then create some equity within our patient population.
Dr. Martin, big picture here, What's most important for cancer teams to keep in mind?
Well, I think taking a bigger step back, and regardless of the order of these questions, I will say Dana's brought up so many good points, and I wish I could just say piggyback that and applaud that comment. But a few things just in general that stand out is that we all have a role in SDOH and in health equity. Those roles are different, but we all have a role. Everyone within our health system or within our practices do have a role, and being able to have better role definement, but also aligned values around that and understanding its importance to healthcare delivery is essential. And the second thing about screening is actually quite different from data collection. And if we were to think about any process where, for cancers, where we think of screening, clearly we would understand that just getting a mammogram is not the true intentionality of screening. It's that data collection, which is identifying an abnormal finding on a mammogram, is supposed to link to an action step that changes the trajectory of that patient's care. And so without that action step, and that's going to be informed by a number of different healthcare roles within our practice and within the healthcare system, that this really is still a matter of data collection.
And what should we know when planning to implement a Spanish version of this tool?
We can collect this data. We want to make sure it's of high quality, that it's accurate, that if there are changes in time over the patient's journey, if they suddenly have more needs or less needs, that we can capture that in real time. But the who, what, where, when, why, and how really matters. And it's so much bigger than just having a Spanish language form or a tool per se. It really is about reaching out into that community and understanding who is the best person, what is the best role to administer this, how frequently, are there different options for people with different types of health literacy? So I don't have an answer right now, except to say that if you want to build and design a successful program, you have to start with the right questions and the right people. And so that's what we're very excited about in piloting this is, what are those questions? And if we can disseminate that how-to and that approach to other programs that are trying to figure out, well, how would we do something like this? I think there's not enough literature and publications and dissemination out there right now about those how-to answers.
Dana, what challenges came up for your team?
I think definitely the challenges are just the busyness of everybody in the clinic. I know everybody wants to do the best that they can for our patients. So just really helping them understand how important SDOH is, because we're all working toward one goal, and that's to have the patient have the best outcome possible. So not forgetting these essential pieces that, if left unaddressed, could negatively impact the patient. I also want to point out one thing that Dr. Martin had alluded to, and that's just all of the people involved that make this possible. It takes a huge amount of people on the team to be able to come together to this one cause. And that's something that I really liked about this ACCC pilot, is that we were able to have multiple cohort sites. So we were able to get on the phone calls and be able to bounce ideas off of one another, because like Dr. Martin mentioned, they're doing great things there. We could learn from them. We could learn from the other institutions that are all globally looking to do the best thing for our patients. So I did want to point that out too.
The screening tool included some questions about clinical trial awareness and interest. Do you think asking these questions helped drive participation to trials?
I do, because again, if we're not asking the questions, then we don't even know the patient's interest or intent to participate in a clinical trial. So asking the question just opens it up for further discussion, further referral, further interest. That's actually one thing that we would like to put in place, that if we're asking this patient that question, if they are interested in clinical trials, we don't just stop there, and that we could maybe integrate into our EMR a better referral process to our clinical research team, and even to the provider that's seeing that patient, to gauge their interest and then be able to talk to them a little bit more about the clinical trial options.
Dr. Martin, how did your team look at the questions on clinical trials?
Yeah, well, I was really intrigued by the addition of those readiness for research questions. And in one ways, that was just another reason why our company wanted to pilot this tool, while we don't feel that they connect necessarily to an SDOH screener, we do feel that they're essential questions to be asking patients. And to the extent that patients are interested or aware of research opportunities, but embedded within those questions were a list of barriers that might preclude them from participating, then it really does intersect with SDOH and health-related social needs. We looked at it as a tremendous opportunity, both at an individual level and at a more aggregate level. Again, having 38 clinics and a growing research program now with Greco Hainsworth Center for Research at Tennessee Oncology, one of the critical next steps within research due to FDA pressures and requirements is how do we make diversity in access and participation in clinical trials grow? And the answers to that are going to be different in microenvironments and in clinic environments. So being able to capture data around patients' interest, their awareness, and their barriers, and being able to cross-reference those three things to better focus strategies around enrollment, but also meeting patients' needs, that if they want to participate, that they can, to meet them where they're at. That's just going to be gold as far as information to help you know where to go as a company. And then also, when that patient's ready, to help get them onto a trial.
And I also have one more addition to that, if that's okay. So, we know that there are demographic disparities in clinical trials. So asking that question of all the patients really aids in ensuring the equity and then the opportunity for clinical trial participation, because at least we're asking the question, we're opening up that door to help close some of those gaps in those demographic disparities.
What advice would each of you share with your colleagues looking to develop a standard process for SDOH screening?
Go for it. There's never going to be a right time, and it's messy. When I was hired through my company as in this new role that they created for me, Director of Health Equity and Community Engagement, you feel like maybe in the beginning you're not making a lot of progress, but that's because you're learning how to operationalize an SDOH system and kind of integrate it and layer it in to our pre-existing healthcare system. That takes a lot of relationship building. That takes learning different roles and what could work and what won't work. Having the courage to test things that you will abandon so long as it doesn't hurt patients. Having that North Star that everything does have the intentionality of providing better value and care for the patient. But you got to go for it at some point. And I can tell you that the requirements are likely to only get harder. Accountability in the space is likely to only get greater without necessarily investments or securities that there's going to be payments behind them or reimbursement behind them. We're here, I think, as a resource. We want to, not just this podcast, but our company, and I'm sure Dana feels the same way, and why I so appreciated what ACCC did in making this almost kind of an open source pilot where we could learn from each other, share both internally as a company, across companies. This is something that I really enjoy doing as the other part of my job, because in this space, really, people do play in the sandbox together. We're all here to support each other to get the job done and do the best thing for our patients. So again, my overall thing was just please go for it. And then humility is the second part. I think one of the other reasons people don't go for it is they're worried of offending people. If you need to read books or do things on emotional intelligence, I still make mistakes. I still say things, but then you apologize and you learn how you can do better and you move on. And if people genuinely sense that your heart is in the right place and that you're putting their interest above yours, not to meet quotas, not to meet metrics, but to meet their needs, and if they can really genuinely feel that, and you'll learn and grow in the process as well. So go for it, be humble, and play in the sandbox together.
I would say what we felt was best at the beginning was to formulate a team. We developed an SDOH team here at the Cancer Center at Mosaic, and it included members who had a really strong foundation, just a foundational understanding of SDOH, and they all had the desire to address SDOH in our cancer clinic. So that, I think, was essential. And then, of course, like Dr. Martin had said, it gets more people engaged and involved that are all wanting to do the right thing and the best thing for the patient. And then so having that group be able to communicate and discuss, and then go out into the rest of the cancer center and start engaging more people who also want to do what's best for the patient. I just think that was really critical. And again, I think it just all comes down to we all want to do what's best for the patient. So just get engaged and get involved and get the support you need. Mosaic has been great to help us support any educational needs and anything that we needed throughout this QI project. And then, of course, utilizing the ACCC resources has been incredible. The ACCC library was very important for us, and it opened up some doors for us to provide different resources to our patients.
Thank you to our guests today. You can head to the show notes for more about ACCC's comprehensive SDOH screening tool. Until next time, for the Cancer Buzz team, this is Summer Johnson.
This show is a resource of the Association of Cancer Care Centers.